Thank you. I'll next introduce Peter Slickman. Pete Slickman. Dr. Slickman is a clinical research pharmacist in the drug development unit at the Sarah Cannon Research Institute in Denver, Colorado. Sarah Cannon Research Institute is, of course, headquartered here in Nashville, so welcome to the home, sort of in a way. Not really home for you, but for Sarah Cannon. So welcome.
All right, good morning. Thanks everyone for coming out, and thank you to TOPS and ACCC for inviting me out here from Colorado. Let's see here. Just going to jump into the objectives here. Pretty straightforward objectives. I want to briefly discuss some of the changes that have occurred across oncology treatment over the last 10 or 15 years. Is that better? Okay, sorry. Identify some of the challenges that exist, and this kind of will tie in with Dr. Kim's presentation, some of the challenges that exist when providing patient education and counseling, and what some of the guidelines are out there available to help assist with that. And then lastly, to kind of focus on some of the issues with medication adherence and show you some of the existing tools that are out there to help with that. So the NCCN anti-emesis guidelines lists about 63 available oral anti-cancer agents, and it's probably likely that there's been a couple more that have been approved by the FDA since the last update. And the rate of growth of oral oncolytics is expected to be about 20 to 30% per year, and about a third of the drugs currently in the existing pipeline are being studied as oral formulations. So there's several different reasons for that. Patients and even some providers tend to prefer oral agents because they're considered more convenient, they're considered less invasive. They can also help provide patients a sense of empowerment and make them feel like they have a little bit more control over their therapy. So we know that it's generally the case that when something new comes along, there's both pros and cons, and it's no different with oral oncolytics. They provide patients with more convenience, but they also present new challenges both to the patients and to the healthcare team, as Dr. Kim kind of mentioned. So I've listed a few of the major challenges here, but due just to interest of time, I'm going to focus mainly on education, counseling, and then adherence. So probably the biggest single challenge that has arisen with oral oncolytics is with patient education. It's been shown to be the most important factor in improving adherence and is considered the cornerstone of successful treatment. This is partly makes it is what makes it challenging is the fact that patients are at increased risk of drug-related problems, and this is due to the increased number of medications, an increased risk of drug-drug interactions. A lot of these drugs have metabolism effects that can affect other drugs and be affected by other drugs, and then also non-adherence due to the complexity of the regimen. So optimal patient education allows the team to assess the patient's ability to take the medication and to adhere to the treatment plan. So this is a good opportunity to assess, as the patient able to open their pill bottles? Do they need specific non-child-proof caps on their medication bottles? Are they able to swallow medications appropriately? Things like that. It also helps to foster a good working relationship between the patient and the healthcare team and makes the patient more likely to ask questions and follow up. Unfortunately, providing patient education can be difficult, and there's a lot of different challenges out there. The first is just general patient information overload. The amount of information that's being presented to them can be overwhelming to many. And then another thing that was touched on in the last session is this reimbursement. So it can be hard to spend 30 to 45 minutes educating a patient and counseling them if they can't be billed for. The other thing that was mentioned previously was documentation. So a lot more clinics and healthcare teams have electronic medical records, but some patients, or some clinics are still on a paper chart. In fact, one of the ones I used to work for is still using a paper chart, and it's a fairly large heme practice. It can be much more simple using an EMR, especially if you can have standardized templates. And then staffing and space considerations can be a big issue. Not every clinic has dedicated space to provide patient education. Not everybody has the staff to be able to do 30 to 60-minute education sessions multiple times a day or multiple times a week. And then lastly, it's just important that because patients are going to interact with a number of different members of the healthcare team, just to provide a consistent message across all of the different members to reinforce the relevant information. So now that I've mentioned some of the challenges, I want to go through some of the things that are considered best practice when counseling a patient. These have been shown to improve patient retention of information, and hopefully that leads to better adherence and then eventually fewer side effects and better treatment outcomes. So it's important to have a standardized approach so that all patients are getting the same information. However, it's also extremely important to recognize that every patient is going to learn differently, and so you have to be able to adapt to the individual patient and make sure that you're presenting things in a way that they're going to be able to retain and remember. Ideally, it's best if the first session can occur prior to the start of therapy. Already when people are starting on therapy, it's kind of a busy day, a stressful day, so if you can do that prior to them starting, that makes the most sense. Ideally, you want to have this happen in an area that's private, free from distraction. A separate visit that is specific for education is great to be able to do if that's possible within your practice. And also having the patient bring along a family member, a caregiver, or a friend can help increase their understanding of multiple people taking notes, multiple people taking questions. Sometimes that's easy to do, but it's not always possible. And then lastly, just to be able to allot enough time. So at least 30 minutes is probably the minimum. Make sure that patients have plenty of time to ask questions. Make sure that you can ask them to repeat back information to you so you're confident that they understand. And it's our responsibility as members of the healthcare team to ensure that patients are adequately educated and they can take responsibility for self-administration. So counseling should be performed by somebody with specialized knowledge. This can be a physician, an advanced practice nurse, PA, pharmacist, anybody that has advanced knowledge. It's really important to assess the patient's ability to understand and to self-administer these drugs, as well as be able to identify any potential issues that might come up with their treatment and them following along. It's important that the information is documented appropriately in the medical record. Again, Dr. Kim kind of touched on this. One of the things that you can use is a standardized note template. I'll show you a couple examples of ones that I've seen in the past and even used. And then lastly, there should be a plan in place for follow-up just to make sure that patient has an opportunity to express any concerns, ask any questions, and even if they don't have any, it's nice for them to just hear from the team and make sure that they feel comfortable and confident with the members. When counseling, take into consideration that most patients have a very limited health literacy, so you have to make sure that the material is presented in such a way that they're going to understand it and be able to follow along. This would include speaking slowly and clearly and then focusing on the most important need-to-know information and not get them overwhelmed with too much stuff. Presenting patients with written materials allows them to take notes, and they can review materials after the appointment. It can also be helpful to utilize calendars, medication diaries, pill boxes, etc. But typically, the suggestion is that all written information should be written in an 8th grade reading level or lower so that people can understand. It also should use plain language and try to avoid any medical jargon. The best way to usually assess whether patients are understanding things is just ask them to do what's called the teach-back method. So this would be where you've presented them all of the information. You ask them, okay, well, tell me exactly how you're going to take the medication. Tell me what you're going to do if you miss a dose, those types of things. And the other thing I want to mention is that there's cultural considerations. So you might not always be speaking and educating a patient who speaks the same language as you as the educator. So it's great if you have opportunity to utilize interpreters, and if you're going to give patients any written materials, to have them translated to their native language. So here's an example of a note template that I used to use when I worked at the VA in Denver. About 90% of our counseling sessions were done over the phone. And so basically what I would do is fill out as much information, the objective information, so labs, previous medications, what the dose is, those sorts of things prior to talking to the patient. And then I would fill in things as I would go. We would get on the phone and I would just kind of be typing furiously and fill out any information that we had, so we would document all the different pieces. This was really helpful for me because I was able to follow along step-by-step approach, and that way I made sure to hit on every point. This is another example. It might be really tough to see because there's a lot of information. Sorry about that. But this one has even more detailed information in it. Is I think a note about capecitabine, and it's more standardized. It has some information, very specific information about administration, and even some tips for managing side effects. Now I talked a little bit about how to conduct the session. I want to talk about what needs to be included in the session. So ASCO and ONS have developed guidelines for what to include in a patient education session. This includes some pretty standard things like the medication name, so both brand and generic name, a very simplified description of the indication for the drug, so used to treat the cancer, used to treat the tumor, that sort of thing. Probably the most important piece to touch on, and it seems like a lot of people are doing this based on the survey results, is to talk to them about the administration. So this includes what is the dose, so how many tablets do they take per dose, how many doses do they take per day, what is the frequency and schedule, are they taking it every day, are there days that they are off, so you know, there's some regimens that are 4 days on, 3 days off, or 5 days on, 2 days off. There's a lot of tools that we can use when I talk about adherence. I'll touch on some of these things to help patients with that. And then one of the things that it looked like was missing in a lot of the documentation is for missed doses and vomited doses. So all of these are going to be different depending upon the package insert for the drug, but it's really important to educate patients about what to do. And doing this in the beginning might help save a phone call later on at the end, or potentially side effects if they're doubling up on doses and they shouldn't be. And then the other thing with administration is just the food effects, so whether patients should take it on a full or empty stomach, and any foods that they might want to avoid, so grapefruit juice, Seville oranges, things that might have some metabolism effects. When discussing side effects, make sure that the patient is aware of what to watch out for, so the more common side effects, some of the less common, and then the more rare but serious side effects. It's also really important to make sure that they know when they should contact somebody in the clinic, so persistent or severe diarrhea, fever, nausea, vomiting, those types of things. The counseling session is also a great opportunity to talk about patient adherence, so you can talk about and fill out medication diaries, patient calendars, things like that, help them fill pill boxes. I always like to talk to them, backing up a second to side effects, about what other medications we might be giving them to help prevent some of the side effects, so Zofran, dexamethasone to help prevent nausea, things of that nature. And then lastly, just to make sure that the patients have all the correct contact information available to them so they know who to call when side effects arise and what to do after hours. As far as storage, the patients need to be aware of how to store medication in order to maintain the integrity of the drug. And in terms of safe handling, make sure that they're aware of proper handling of these agents, so hand washing both before and after handling. If they have a caregiver who's going to be handling drugs, be aware to wear gloves and use other protective equipment. As far as safe disposal, just make sure that they understand that these drugs should not be thrown in the garbage or flushed down the toilet or thrown into the sink. There are some different city and county depots that are available. Even some clinics will take back medications, but that's just kind of on a city-by-city, county basis. And then thirdly, just the process for obtaining the medication. Ideally, if they can use one pharmacy for all their medications, that works the best. That provides easier documentation. If you're a private practice trying to get in touch with somebody, you can call one pharmacy. They hopefully have all the information. Plus, a lot of these different specialty pharmacies will use one primary drug interaction database, so if all of their meds are included in there, the drug interactions are going to be more accurate. So MASC has developed a teaching tool that it was developed by some oncology nurses and educators, and it follows a very structured format to ensure that all key areas of patient education and teaching are addressed. And it's actually now been updated to include or be translated into 17 languages. So here's just an example of it. This one actually is able to be cut out and folded into a pamphlet. So the tool is split up into 4 different sections. So the first section lists some key assessment or key questions to assess the patient's knowledge of the treatment plan. The second section contains general teaching instructions that are applicable across all agents, all oral agents. The third section provides an area for drug-specific information. And then the fourth section lists questions that may be asked to ensure that the patient has understood the previous and above information. That's the third and fourth section, sorry. Another thing that I did when I worked at the VA is I kind of felt like I wanted all of the patients to get the same information when they came in, whether they're getting IV therapy, oral therapy, or some combination. So we wanted to present a consistent message and have some resources and tools that people could look at when they left our clinic. And so my pharmacy resident and I at the time developed some documents and basically a teaching / welcome packet. So I put in a couple of, the next couple slides, show you some of the things that we did there. On the left side is just a list of various members of the healthcare team and a brief summary of what their role might be in that patient's care. On the right side is just sort of what to expect on a clinic visit day. So it tells them where to go, where the lab is located, how long the lab might take, how long to expect for their oncologist appointment, and then if they're getting IV therapy, where they need to go, which room, and how long to expect to be in the infusion center. The next two here are just some more general information. The left side has some general information about oral chemotherapy. The right side is just some general nutrition tips. So there's a table in there. It might be really hard to read because it's small, but some things like maybe avoid these fried spicy foods to help protect your GI, some other possible better options to choose from when it comes to nutrition. And then we also created a pamphlet-style handout that discussed general side effects of chemotherapy and some suggestions for minimizing toxicity. So this is the first couple parts. What is chemotherapy? What are some things to know? What are some side effects to watch out for? And then I only included a couple of these. It's probably about a 12-page document or pamphlet, but the left side, just some nausea and vomiting tips to prevent it, tips to treat it, diarrhea, and tips for managing hydration, and then some brief information about alopecia. So now that we've pretty thoroughly covered education, I'm going to talk about medication adherence as it's directly impacted by the quality of patient education, and it's an essential component of success with these agents. So the most common definition for medication adherence is the extent to which patient behavior corresponds with the recommendation of a healthcare provider. So that's a bit of a mouthful to say, but there's no denying that non-adherence can have an extraordinary impact on healthcare costs. This can be due to disease progression, complications and side effects, maybe hospitalizations, and some estimate the costs to be in the billions annually. So there's a lot of different factors that can influence medication adherence, including disease, medication, patient, and system factors. So you can kind of see in the 4 quadrants here that some of these, there's some overlap in the different areas, but there's a lot of different factors that go into this. And various published articles have attempted to determine why patients may be non-adherent. These are probably some of the more common reasons reported. I would say that probably based on my experience, I would assume based on all of yours, is that the biggest issue is just number one, carelessness or forgetfulness. So we've probably all been on some antibiotic regimen or other drug regimen and forgotten to take a pill at a specific time or forgotten to take it altogether. It's no different for patients on oral oncolytics. So I'll talk about some of the tools that we can use to help with this main issue in a couple slides here. But some of the other reasons that patients have reported are just concern over toxicity and side effects, lack of understanding of the written materials, lack of understanding of how to dose. So that's why the education piece is so important. And then costs. So there's a lot of, these drugs are very expensive. Patients have very high copays. Sometimes people think that if they cut their dose in half, they're going to get the same effectiveness, but be able to decrease the amount of money that they have to pay every month because they can extend out the prescription. So one huge factor in improving adherence is just actually figuring out the best way to assess it, and it can be very difficult for a variety of reasons. The biggest reason is that there's just no consensus agreed upon definition of what it means to be adherent. So the simplest formula is just to take a percentage, the number of doses taken divided by the number of doses prescribed. So if a patient's prescribed 20 doses, they take 19, they'd be considered 95% adherent. But unfortunately, this doesn't tell us the whole story. It just tells us a percentage number. It doesn't give us any information about why the dose was missed, any sort of pattern of how the meds are being taken. Patients could have missed 2 doses and then doubled up to get up to that 19. It doesn't give us a reason for the medication, why it was missed, and it's hard to come up with strategies to help patients if we don't understand the entire picture. So another challenge is just determining what is considered clinically significant. So in the example I used, a patient missing 1 dose out of 20 would technically not be 100% adherent, but is that clinically significant? And there's not really much information out there to tell us whether it is or not. I think most of us would probably suspect that missing 1 out of 20 is not significant, but there's not a lot of data. Another factor is just figuring out how to monitor adherence. Relying just on patient report is not always accurate. And there's a lot of indirect and direct methods, but a lot of them are very tedious, and a lot of them can be manipulated. So it's hard to trust some of these measures. There was a study done a couple years ago that looked at capecitabine usage, and the authors noted that, I think it was only a very small study, about 19 or 20 patients. Based on patient report, they were 99% adherence, but when they looked at this medication event monitoring system, which is a system that measures and tracks every time a pill bottle is opened, the adherence rate was only 61%. And when they dug a little bit further, they realized that patients were annoyed with using this other system, so they transferred their pills to a different pill bottle to avoid so they ultimately conclude that combining several different measures of adherence can maximize the accuracy. So the literature that's out there suggests that even though cancer patients may be especially motivated to be adherent, they still struggle. There's a couple references here that demonstrate that. And actually in the NCI study, the authors noted that adherence rates for long-term therapies are still hovering in the 40 to 50% range. So that's really pretty poor. We know that adherence is important. We know that it's challenging to measure. We know that some patients are not particularly good at it. So what can we do? Well, that's also a difficult question to answer, because there's some challenges that are easier to deal with than others. So access and cost-related problems can be helped lessened with use of specialty pharmacies or even manufacturer financial assistance programs. Regimen complexity may be decreased by rounding doses to only 1 tablet strength. Now, some drugs make it easier than others. Temozolomide is notoriously one that's really challenging to do that with. But the fewer number of drugs that a patient has to take per dose per day, it's going to make them much more adherent, generally speaking. Then just dealing with depression and other social issues, that can be assisted if you have access to psychologists or social workers. There was a meta-analysis done in 2008 that looked at 61 studies that were looking at adherence, and they found that no one strategy was consistently better than any other, and even the best ones that they found had a really relatively low impact overall. So having said all that, there are some tools out there available to us. Most of these kind of focus on that first issue that I mentioned earlier, the forgetfulness or carelessness. Patient calendars, med diaries, and pill boxes are definitely the most utilized listed here. They can especially be useful when patients are on more complex regimens. So as I mentioned earlier, if they're not taking the medication every day, or if they're taking it multiple times a day. Alarms can work. I'm sure all of us use cell phone alarms for various things, alarm clocks, but easy to hit the snooze, easy to ignore if you're not right by your pill, and then just forget to take it later. Blister packs are something that's sort of similar to pill boxes, but it can be difficult to find pharmacies that will do it this way, and also adds increased cost to patients. And then electronic pill bottles, some of these can actually talk to the patient, but again, it adds a lot of cost, and they're not really that widespread in use. And then the MEMS system that I mentioned earlier is really kind of a really interesting, unique, cool system, but it can be manipulated. If you open the drug bottle, it records it as open, but it doesn't record it as being actually taken. So that's kind of a tricky thing with that. There's some major guidelines out there that outline some of the standards and things that I talked about. So the ONS, ASCO guidelines, they define adherence, outline standards for assessing. There's an ONS toolkit, adherence toolkit out there, and basically their suggestions are to use multidisciplinary team to promote maximum adherence, create structured and individualized plans, and then frequent monitoring, contact patients via phone if necessary. And then NCCN has some guidelines that basically say that we need to assess for patients' ability to adhere, and this happens in that early on education system or session. That there's few systems developed in oncology to support safe and reliable administration. So here's a couple pictures of some of the different adherence tools. On the left there is the ONS toolkit. The middle one is the MASS teaching tool, and then the last one is just cancer care, taking pills for cancer treatment, and this is tips for staying on your plan, so this is something that patients can use. There's a lot of various patient resources out there, especially on the internet. I just want to talk a little bit about some of these here. So almost any tertiary reference will have printable materials that's directed specifically at patients. It doesn't use medical jargon. Lexicomp is a really good one that I've used in the past, Micromedics, chemocare.com, Medline Plus, some of these other ones. As far as supportive care, American Cancer Society is a great resource, and chemocare.com actually has an area specifically dedicated to managing side effects. And then lastly, just many manufacturers have financial assistance programs to help those who might not be able to afford medication. But each program is a little bit different, so it can be, you have to take each one individually. So again, just to kind of summarize what I talked about, oral oncolytics have dramatically changed the way that we treat cancer. While this has led to new challenges, it also means more opportunities for the healthcare team to make an impact. Complete and thorough education and counseling is vital to the patient success with these agents and can help maximize the effectiveness and minimize toxicity. Medication adherence continues to be an issue for some patients. However, there are several tools available and strategies out there that can help with that. Data suggests that there's no one best tool, so combining multiple strategies might bring the best results. And lastly, there's no consensus best way to do things. There are guidelines out there to help us, but each practice needs to figure out what's going to work best for them and their specific patient population. So that's everything I have, and I will try to take any questions.
Thank you for a great presentation. Let's maybe just do 2 comments or questions just in the interest of time, and I'll go ahead and make one, which is that you know, this may contribute in a small way to overall patient adherence, but I've certainly had some patients very distressed about information they get about the dangers of you know, to caregivers of handling oral oncolytic medications, even to the extent, I mean, it's stressful to them, and even to the extent that I've had some patients come back in and say, you know, I was all on board with this, but when I read that, you know, my significant other can't even touch these pills, no way am I putting that in my body, so they won't take them. Is that, can you generalize, it's hard to believe there really is toxicity to people handling or touching the oral oncolytics in their hand for a few seconds a day. Can we generalize about that, about oral oncolytics? Is that truly a concern?
I think for the most part, as long as the drug itself, the pill or the capsule, maintains its initial integrity, I would say the risk is extremely, extremely low. Now, when we have patients that are on oral therapies in our hospital on the cancer floor, obviously anybody who's touching those medications, and we use precautions, so any women of childbearing age don't touch anything. They don't deal with chemotherapy at all. But everyone's using gloves. I mean, when I handle drugs, I'm using gloves. I think as far as inhalation, that's probably not an issue. Now, if you're breaking a tablet, that's something different. If the tablet is leaking, that's something different. Then that's probably more cause for concern. But I really think that, you know, general exposure is very, very small unless the drug integrity has been breached somehow.
I generally counsel patients not to worry about that, and if they or their caregiver needs to handle it, you know.
Yeah, I mean, you can get a box of like 100 gloves for a couple
right.
bucks. So, you know, when they pick up their medication, you know, if they're having concerns about that, and you can buy surgical masks. So there's lots of ways that, you know, can sort of decrease their fears, but there's options out there for sure.
We've got some questions coming in from the webinar. Somebody would like to know if you can recommend any apps that patients can download that will remind them to take their pills or keep their adherence to the regimen.
That is an excellent question. Unfortunately, I haven't really come across too many apps out. I mean, there's a lot of apps out there for healthcare workers. Some of them work better than others. You know, I've not really used a lot of phone applications before. I don't know anything off the top of my head. That's a really great question. Maybe somebody else out there has seen something or used something or recommended something.
They're not super sophisticated, and but of course, you know, they're produced by all sorts of different vendors. So I think when you're recommending apps, just make sure that you're recommending a reputable vendor, because it may be taking potentially sensitive information from the user for privacy issues.
Sure.
There's also an electronic pill dispenser. So I don't have any financial interest in any particular company, but for an example, Philips makes one, and the patient can rent it for $40 a month. The pills are loaded, can be loaded by a nurse or a family member once a month, and when it's time for the patient to take the pill, it gives a verbal, hello, it is time to take your pill, and also a little noise is made. So it's verbal and another type of reminder. There's someone, it's hooked into the phone system, and there is someone that it calls. So if Mr. X doesn't take his pill within 45 minutes, it calls the notifier, the person who's to be notified. And they're great. So that's another option.
Yeah, I think that's something that people don't, maybe the awareness of those things is not really, you know, the manufacturers of those maybe need to do a better job of like getting the word out, because I've heard of those, but on even putting together these slides, that wasn't something that, yeah, I just never see it. I hear about it in theory and in you know, research projects, but never have actually seen anybody use it.
So both the speakers alluded to financial assistance programs as being integral parts of prescribing oral oncolytics. I just want to make sure that everybody knows about this resource. It's the ACCC Patient Assistance and Reimbursement Guide. It comes to members, and if you're a TOPS member, you should be getting this at your office. And I don't like to advertise for ACCC, but I will tell you it is a comprehensive resource, and it is available in a digital format. But this little magazine, I give it every year to our patient advocacy people, and it's got all the websites, all the drugs, all the manufacturers, and how to access those patient assistance programs. And I have to tell you, this is probably one of the more valuable resources that I've found in this particular area.
Yeah, I've been very lucky in that, you know, there's a lot of pharmacists that do a lot of that stuff, but I've been fortunate to work in a VA and then work in a bone marrow transplant center and then now work in a phase 1 unit. So I haven't really had to deal a whole lot with insurance, thankfully, but there's definitely people out there that can do that. So I think we're kind of running out of time here, so I'm going to get off the stage. Thank you, everybody, for your attention. Thank you for having me.